Fabulous. So, welcome everybody to the Oldham Primary Care Commissioning Committee. Have we got everybody that we need to be here? We've got a minute taker, Erin. Shaz is here, yes.
Yep, Shaz is here and we're
Morning, Shaz.
Morning, Mike. You all okay?
Yeah, sorry, I didn't see you there. I did in the background. Righty, we're going to get going, Shaz, if that's okay.
Fine, yeah.
So I'm assuming that everybody on this call knows each other. Welcome, Carol, who's here as Kate's deputy, who's now gone off to pastures new. So Carol's here supporting us from a financial point of view. Kath, do you know everybody? Fabulous.
Yes,
So
yes, thank you.
we're all good. Everybody knows each other. Have we had any?
Sorry, Mike. Who is Andy?
Oh, Andy's from New Image. They're the people that support the live streaming process for us, Carol. Sorry.
Thank you.
Have we had any apologies, Shaz?
Yes, Nicola Hepburn.
Okay, thanks very much. And I'm assuming that the only declarations of interest are from Dr. Patterson, which are in the register. No one else has anything on the agenda today to declare? No. Okay, good.
Mike, will I do a verbal as well as that paper one, just for it's a public meeting?
Yeah, can do, John. I'm going to move us to the minutes then. So the minutes of the 3rd of May. Do we all agree that they're a true and accurate record of the meeting of the 3rd of May? I'm seeing nods, so we'll take them as read and sign them off, and then we'll move down to the action log, of which there are only 2. First one for yourself, Marion. New type of report to the next meeting.
In relation to primary care quality assurance, right?
Yeah, so we were talking about quality care performance and assurance.
Yes, yeah. There's been no more inspections in Oldham since the last meeting, so we will present that new format of report once there's been some more visits by the regulator.
Okay, so we'll leave that action open then for now.
Thank
you. The special allocation scheme is completed, unless Erin's going to tell me something different. No,
that's gone over to the team for information.
Fabulous, which then takes us on to the meeting proper and our very first agenda item, which is item 5, Population Health Management Locally Commissioned Service Scheme for 23-24. Marion.
Thank you, Chair. This paper is coming to committee today to seek approval of the proposed indicators, targets and thresholds for the 23-24 scheme. I should add that we are still in a consultation period with all our stakeholders, and that consultation period will run until the end of June. So while we need this agreement today in order to move the scheme forward, we are still open to comments, questions and input from all our stakeholders into these indicators and thresholds. So as the committee will remember, you've previously supported the high-level principles for the scheme, which builds on the population health management approach adopted in last financial year. All the areas of the scheme, be they prescribing, shared care, diabetes, respiratory and frailty, are compliant with clinical best practice in respect of the care of patients with those conditions. Specifically with frailty, we are looking to broaden already accepted clinical management standards for those with severe frailty down to those people who have been assessed as having moderate frailty. This is due to the fact that 30% of people in that category of being over 65 will fall in the next 12 months. And that has multiple risks for them, both in respect of the human cost, distress, pain, injury, loss of confidence and independence, but also increased mortality. And currently, 30% of our over 65 population would exceed all of those currently coded with moderate and severe frailty in Oldham. And therefore, we feel it's really important to have that element of proactive upfront management included in this scheme for this year. I know that the committee will have read the paper. You will note that in respect of glycemic control 3.2c, there are currently no target thresholds in there. This is because that we want to recognise a reduction of HbA1c in patients with diabetes rather than measuring an absolute, because of the clinical evidence that supports the positive outcomes to their care. However, we are having some challenges in respect of data quality and being able to extract that reliably from clinical systems. And that's why today we haven't got the baseline and we haven't got the thresholds in there. However, this is a clinically evidenced intervention to improve outcomes for people with diabetes, so we will continue to work between now and the end of June to establish that. We have had some comments and feedback from stakeholders on the scheme so far, and we will be including all of that in an FAQ and bring those comments and questions back to the committee for verification. We will be breaking down, because one of the questions has been around what is included in a COPD annual review, a diabetic annual review, etc. So we will be breaking that down and making that absolutely clear for stakeholders. So at that point, does the committee have any questions or comments on the paper and the proposed indicators and thresholds?
John.
Thanks very much, Chair, and thank you very much, Marion, and your team for getting this paper together for us and this proposal. And what I'm aware of is it doesn't quite communicate the amount of engagement and work that has gone on. So I know there's been open invitations where the majority of GP practices have taken to come and discuss the scheme with you and really get into the granular detail. I know we've met with our local PCN leads. I had a very profitable conversation with them. I know they've been very helpful in vocalizing, concerns. Not so much with the content, but just some finer details, some of which we know are still to come, such as the financial read across to the various thresholds and those lines. That is work to be done, and we look forward to the ongoing engagement work. I think we have to be mindful of what we're trying to achieve here, which is addressing health inequalities and resourcing general practice, that every neighbourhood in Oldham has the chance for the NHS to be best where it's needed most. And so I'm confident in my GP colleagues that this scheme will allow them to deliver that. And certainly we've seen in the past Oldham setting the lowest exception rating. So we make the least people invisible here at Oldham who have a long-term condition, and also the work around case finding. And we've had other good work from Oldham West, who have done some really good work about COPD inhaler confidence. We have all the good work that we can build on of COVID, and the sort of local collaboratives that this work will build on. There are some stretches I see and recognise in this paper, and those stretches do need to be run in the real world. So we have to, and we've always been good at that, Chair, where we have. I remember a couple of years ago we had a very high stretch for severe mental illness physical checks. The stretch was so much that it was about 60% above the current Oldham achievement. But then we discovered as we went on that it was 40% above the national achievement. So Oldham achieved something that was 40% above national achievement. However, we did move the thresholds back to reflect that the achievement of the Oldham family of GP practices had been so significant. And so some of these things you can only test in flight. And so we believe that we do have an engagement plan. Going forward. We're very happy to bring that engagement plan back to this committee. Very happy to stress test that engagement plan with our CD, PCN leaders. So those are my comments. It's a really good scheme. You know, remember 10 years ago we had schemes where we were chasing around just to see if GPs had conversations about prescribing. There's some real publicly available figures. All this data is on Tableau. I do think there's quite a lot of work to be done. Now the scheme, should the scheme be approved today, in helping colleagues understand it. I have not had a conversation with someone where more information has led to more unhappiness. More information has led to people's cortisol settling, and there's real resolve from our managers and our nurses and our doctors that this is doable. And let's take a deep breath in at some of the stretch, but this is what the people of Oldham need, and this is the resource that the providers need to deliver that. So I am strongly recommending this scheme from a clinical point of view, and just grateful for all the work that's gone on it. Thank you.
Okay, thanks, John. Tamar, welcome. We're on the first agenda item, which is the Population Health Management Scheme.
Hi.
For those watching,
I was stuck on a call.
No worries. Tamar's from Health Watch. So I guess I've no questions really, Marion. I agree with John. I think this is a great scheme, well worked up, well thought through. It's got significant amount of stretch in there that's also achievable. I think from today's point of view, given that I think we're committing that there's an additional round the table set of discussions we want to get to just to make sure this lands properly and appropriately, I think we're probably suggesting that we adjust the recommendation. So I think the recommendation is that we accept the fact that we want a locally enhanced scheme in place, and this is that scheme. When it comes to the detail of the targets and thresholds, I think we can confidently say that we would allow a further set of engagement exercises to road test that, make sure they're all right. I think if there was a fundamental change on indicator, though, that's probably something that I would want to sit down with John from a clinical point of view and have a real clear idea about, is this the right change? But scheme fine, indicators broadly okay, targets and thresholds, let's have a further set of conversations. There may well be some financial implications that we want to make some adjustments as a consequence of. And I think that gives us an opportunity to not only discuss this with the practices, but also with the primary care network directors as well. I think it's quite important we've got all sides of the jigsaw lined up around this. And if we do that before the end of this month and get to a final conclusion, that would be a proposed way forward. Are people comfortable with that? Fabulous.
Thank you,
Righty.
Chair.
No problem. Let's move on to the next one, which is the asylum seeker contingency provision enhanced scheme. Is this you again, Marion?
It is. Apologies, I couldn't find the mute button fast enough. Yes, okay. So the purpose of this paper is to seek approval of a tender and quotation waiver to secure ongoing delivery of primary care medical services to asylum seekers living in contingency accommodation in Oldham. While asylum seekers face many of the same health needs as the UK population, they may also have poor awareness of the NHS and fear barriers to accessing treatment, come from countries of origin with poor healthcare, suffer health impacts, mental and physical, after leaving their country and being detained in the UK, have experienced war, conflict or torture, and be separated from family, have poor housing and be socially isolated. Since December 2021, we're very grateful to Medlock Medical Practice for providing primary care medical services to the residents of the hotel in order to provide them with sustainable healthcare, access to care, and recognising that everyone in the UK is entitled to GP services. And therefore, the purpose of this paper is to request that the committee approve the waiver and the funding for us to be able to support Medlock Medical Practice in continuing to deliver that care throughout up until the 31st of March 2024. I hope that gives a sufficient summary of the paper. Does anyone have any questions or comments?
John first, then Tamar.
Thanks, Mike. So I won't do this for every item, but just because this is a public meeting, I I'm a working GP. I am, however, not involved at all in anything to do with the Medlock to stop people having to rush off and see which GP practices I'm involved with. I'm also, as the AMD, involved in quality processes, and I do note that Medlock had a CQC inspection, and their delivery of this service was highlighted by the inspector as outstanding, and they made particular mention of a first language pharmacist for some of the residents at the accommodation. So I think the committee should be aware of that as an advisor to this group, that CQC have been in and had a look at the service provided by Medlock and have rated some features of it outstanding. I do think there's a small leak of patients leaving the accommodation and seeking other GPs, but certainly the ones I've met aren't doing it out of any complaints about the service, but just rather that's a natural sort of spread of the assimilation of these vulnerable people into our society and community. So I welcome that, and I certainly don't think it's at any level that would change the paper today. So I wanted the committee to be aware of those two things. And you know, we don't often get a chance to highlight outstanding practice in Oldham, but Medlock, I think, should be praised for this. Thank you.
Thank you, John. Tamor?
Thanks, Chair. I just want to follow on John's point, equally praise Medlock for the work that they've done in this regard. I think in the paper, the initial bullet points that kind of sets out the experiences that asylum seekers and refugees go through in accessing primary care, I think it is very poignant and something that we need to give more focus to. People may be familiar in other settings that from a Health Watch point of view, certainly on our work plan, we are through the British Red Cross. We're part of the steering group around asylum seekers and refugees, and one of the issues that have come out is the barriers, the significant barriers that all asylum seekers and refugees are facing. Obviously, we're only picking up what's happening in Oldham, but they're facing with a number of practices in Oldham. So our soft intelligence suggests that there is a piece of work to do here. You know, it sounds like Medlock could potentially be the champion, as in an exemplar of how they work with and deal with asylum seekers and refugees. But just putting the ask out there, so it's on our work plan. I think this paper is very timely. Really pleased to see it. If we can build on this, in terms of from our point of view, in line with the paper actually, those exact bullet points that talk about the barriers that asylum seeker refugees face are the exact things that we would like to take up. So we're proposing survey and engagement with asylum seekers and refugees to understand further and kind of formalize what their experiences are. And I don't know whether this committee would be the right place to bring it back to. I'm happy to have conversations with you, Marion, and other people outside of the meeting. But I think this could be a really, really beneficial piece of work on all fronts.
Okay, thanks, Tamor. So I think what we're basically saying are three things here. So first of all, the continuation of the service and the waiver sign off, tick, done. You know, the paperwork's here, no one's disagreeing with it. Medlock want to continue, we're happy with the service, there's no reason why we would withdraw this service or change provider. So let's get that bit out the way with, and that's great. I think there's a second thing here. It'd be prudent, I think, for myself to write to Dr. Chohan, isn't it, Medlock Medical Practice, to thank him for the service, express our gratitude, thank you for the outstanding work that's been done, and perhaps that's a joint letter from John and myself. And the third part is then a kind offer from Tamor, which basically says there's a load of stuff we could learn from all of this. We'd like to work with you to help understand and capture that learning and spread that learning across the whole of Oldham and wider. And Tamor, quite happy to pick up with Marion outside of here to scope out. I'd probably suggest Erin or Mark Drury joins that conversation to scope out what that piece of work would look like. And then I would suggest to more that it doesn't just get contained in this meeting, but we take that to the ICP board, which you also sit on for Oldham as well. And I'll have a chat with Councillor Brownridge about when an appropriate time to schedule there is later this year.
Yeah, amazing.
Erin.
It was only just to say it'd probably be Celeste, our engagement manager, tomorrow. I think you've had contact with Celeste already, but she'd be the right person to support and get involved in this conversation. I'm happy to support as well.
Okay.
Brilliant.
So We're agreed
Thank
on.
you.
We're agreed on that one. Marion, let's move on to the next agenda item, which I believe is Block Lane patient allocation.
Thank you, Chair. So by way of introduction, as the committee will be aware, the partners at Block Lane Surgery took the very challenging decision in January 2023 to serve notice on their GMS contract. We do fully appreciate how concerning and worrying this has been for members of the local community and their representatives. And now we need to ensure that all of those patients are registered safely at other GP practices in Oldham. Following the notification of termination of the contract, our intention was always to secure a new provider to run Block Lane Surgery. Patients were informed of this in early February 2023, and we immediately initiated a procurement process after that date. Unfortunately, that process was unsuccessful and we were unable to award a contract to a new provider. So now we are sadly in the position where Block Lane Surgery will close in early July, and patients now need to register at other practices in Oldham. At the start in January 2023, Block Lane Surgery had a registered list of circa 5,500 patients. Patients were informed of the need to register at a new practice on the 22nd of May 2023. At the time of writing and circulation of this paper, the Block Lane Surgery list had decreased to 3,500 patients. That is now under 3,000 patients, as patients do continue to register at neighbouring practices. It's really important during this process that patients are given the opportunity, as they are being, to exercise their right to choose a new GP practice. And in respect of registrations, patients can register at any GP practice that they live within the boundary of, who has an open list. And all practices in Oldham have open lists. So therefore, what you will find is that a lot of practices in Oldham will be receiving new registrations from Block Lane Surgery. Of course, the highest concentration will be in those practices surrounding Block Lane Surgery, and they are listed in the paper as CH Medical, Kapoor, Littletown, MD Family Practice, Wearmouth and Woodlands. And indeed, I have been in close conversation with all of those practices, and all are receiving significant numbers of new registrations from Block Lane Surgery. However, we will get to the beginning of July and the date that the practice is closing, and we will find that some patients, for whatever reason, have been unable to register themselves at a new GP practice, and therefore we have a responsibility to ensure that they are registered and to inform them of their new practice so they can continue to receive primary care medical services. They are, of course, free to then change and register elsewhere. Okay, we can allocate patients through this process to a maximum of 3 practices, and I have had discussions with 3 practices close by. They are Woodlands Medical Centre, Littletown Family Practice and Kapoor Family Care, and those 3 practices have indicated that they are very happy to receive that final allocation, and that they have the capacity to do so. Therefore, I'm asking the committee to approve that recommendation and agree that the final allocation of patients would go to those 3 surgeries. Does anyone have any questions or comments? Thank you.
I definitely have some. John's leaning in. Do you want to go first, John? You're on mute.
Thank you, Chair. And I'm being slightly more verbose because I realise our LMC reps haven't joined us today. I've contacted them. I'm sorry that they didn't, having worked quite hard to get them here, but general practice is busy. So if I can be this voice of general practice, knowing, as I've already said, that I have no connection with any of the practices here. First of all, the three practices that the committee are asked to consider are very good practices, and if you're not aware, Littletown, having gone through a sticky period, has emerged stronger with an excellent CQC result. And throughout COVID, particularly Shagufta Praveen absolutely stood forward for her patients and for us as a locality. Woodlands have some of the best clinicians and some of the best QoF outputs, and and are an excellent practice. And Kapur family is resilient and large and has a wonderful new building. So these are, let's not miss in this sadness and in this difficult conversation, let's not miss that general practice is alive and well and thriving in some parts of Oldham. And so we have good practices for these patients to be dispersed to. And I suppose I note, just as a GP of almost 2 decades now, that whenever keys are handed back and that news gets public, patients do move, and you get to a point of no return very quickly once you're down to 3,000 patients and falling. And of course, there will always be some vulnerable patients who struggle to make that transition, as we all would, maybe to change our mortgages at the end of the fixed rate and all those other things that we all struggle with. So therefore, I would strongly recommend that the committee adopt this paper and the dispersal. I'll leave other comments apart from that, but I don't want us to miss the fact that there are large parts of general practice in Oldham that are thriving despite the pressures.
Really helpful context, John, and I want to kind of take this in 2 bits, really. So the first bit is Marion's basically telling us there's once this process gets to a certain point in time, it's very likely that patients will need to be allocated, and we'll need to help them to do that. And our preference is the 3 practices listed in the paper, and the paper's asking for a specific recommendation to agree that. Presumably, the logic is the Werneth and MD family practice are either not interested or don't feel they've got the capacity to be able to take on significant numbers of additional patients, whatever that significant word means in this context. Do you want to just come back on that bit, Marion?
MD family practice and Werneth medical practice are both sole contract holders, and when sadly we've been faced with this situation before, we've been very consistent in our approach of not recommending allocation to sole contract holders because of the subsequent impact that they make that would have on their workload.
Okay.
So this is why we've looked to practices who have larger workforces.
Okay, brilliant. Tomo, I'll bring you in before I finish my points, if that's okay.
Yeah, thank you. As you might expect from a Health Watch point of view, I mean, I'm just going to kind of raise a couple of things where I think there could be possible learning, because our concern is that should this happen elsewhere, which, let's be honest, is a realistic prospect, because these things can happen from time to time, especially with challenges that partners and primary care in general is going through. We understand that the feeling was originally earlier on in the process that there wouldn't be any direct impact on the services that were going to be offered, and that there'll be a seamless transition from basically the previous providers who gave notice to then this being retendered. So there'll be the thinking was that there'll be a continuation. Obviously, that's not happened. And I know that it was raised by Councillor Mushtaq at, I forget which meeting we were at, Mike. Was it? I forget now. There's that many meetings.
Yeah.
One of the key strategic meetings of the Oldham locality, where it was raised about accessibility and kind of deprivation and the impact on the local population of not having access to GP surgery for a period of time. So I just think there's some learning here that, if back in February that was the intention, that there would be a continuation, there would be minimal impact on patients from the local population. That's obviously not happened for whatever reason. And like I say, these things do happen. I suppose it's just kind of looking at what learning can we take from this to ensure that should issues arise elsewhere, that there is that continuity and patients do feel that they are getting the care that they would expect.
Okay. And really, really, really helpful comments, Tamo, and a kind of sobering reminder of some of the things that we also need to mop up as part of the conversation today. So this is a bit of a monologue, so you have to bear with me for that. I think the state of general practice right now, as John says, from a technical managerial point of view, I'm really pleased and I'm really glad and I'm really grateful for all the hard work that our GPs give and put in every single day of this week. There are 300 million GP appointments every single year across this country. Put that into comparison with 23 million A&E attendances, you can see the vastness and the difference in the scale of general practice. And everybody knows just how busy A&E is. It's just a shame that people are not crying out in the same amount of feeling about how busy general practice is. And it's of amazement every single day what I see our GPs going through, and for that I'm incredibly grateful. CH Medical that run Block Lane and have run Block Lane have been out to advert for a GP for at least the past 26-7 months and have been unsuccessful. So it's little surprise that with one single GP in Block Lane, they have reached a sad conclusion to say, we can't do this anymore. I have seen personally the distress on Dr. Moore's face. I've seen the pressure that the practice is under and have every sympathy for it. I'm equally incredibly frustrated and disappointed that we put a tender out for two practices at the same time. One was successful and one we couldn't even award the contract because the providers who bid it couldn't even get over the bare minimum thresholds for delivery and quality. And I think there's something quite significant about that, Tamo, and everybody, that we all need to just sit back and think about. I suspect this is more about the pressure that primary care is under, having to deal with patients and then kind of tout for new business and go through the rigmarole of quite an extensive procurement exercise, to be fair. But I can also not be in a place where we break the procurement law and regulation out of convenience. So I think we've done as much as we possibly could to kind of reach a satisfactory position. However, that's probably a very little consequence to the local community, who now, ironically, have lost a building but not necessarily lost any GP coverage. We just simply got one building less to provide services from. The nearest practice, I think, is less than half a mile away, which is Woodlands, I think it is. So whilst that may not be a huge amount of distance, it's still a significant distance for people who are frail and elderly. And I think we need to try and work with that community as much as we possibly can. I do also, at the same time, find it a little bit annoying that CH Medical, having to want to withdraw from Block Lane, still are able to allocate patients or encourage patients to go to Fields New Road. I find that a wholly unsatisfactory position, and that's a personal opinion of mine, not necessarily reflective of our system, and I'll stick with a personal opinion on that basis. And then my final point, having agreed the allocation to the three practices and having just made my rather slightly political statements, I do want us to now start a review of primary care in West PCN as a consequence of this. I think John and I need to be assured that we have the right level of clinical standards and access and delivery, and the right number of doctors to serve that population. I have now seen two practices, both from CH Medical, withdraw from what I would consider fairly deprived communities who are wholly reliant on those facilities in those places. And I think we need to now commit to undertake a review and see where that review takes us and live with the consequences of what that review says. And I'd very much welcome your input to that review, Timur. That's not just about learning lessons, but is actually about learning the lessons and coming to a conclusion that says, do we have the right level of access in the right places for the people in West PCN district, and see where that takes us. If that means that we then have to reconfigure some services over the future term, then so be it, but we'll have a plan to do so. I don't think we're not in a position to be able to instruct CH Medical to change their mind, to not give their keys back, to not withdraw from the contract. all we can do is live with the consequences of it as the contract holders. But that doesn't mean that we should do some planning work about what does the future look like in their area, in those communities. So if people are comfortable with that, if that's something we'll pick up offline from here, we commit to undertake the work as quickly as we can, which I suggest is probably over the summer. We bring a future report back to here in the autumn and take it from there. I think from that, there needs to be then some engagement with local elected officials at both local level and national level. Because I do think actually some of the national politicians here need to make some statements about the level of GP coverage and access in deprived communities. And that's a thing that they could do with the Health Secretary directly in a way that I'm not able to. Marion.
Thank you, Chair. We'll be able to move forward and progress that final allocation of patients. And I'd just like to take the opportunity in the committee to extend my thanks, particularly to Woodlands, Littletown and Kapoor, recognising the massive impact that this will have on their workload and how they're managing that, but equally to all practices who are receiving new registrations from Block Lane Surgery. In the individual conversations that I've had with neighbouring practices, all have been incredibly receptive and willing to help and support what is a very challenging situation for everybody. So thank you to them.
Okay, brilliant. So we're clear about what we're doing now with Block Lane and what the next stages are, A, on the dispersal and then B, on the kind of more strategic question about GP access in that area. Take us to the workforce review paper, Marion, and I'm pretty sure John will have quite a bit to say about this. It's, I know, something dear to his heart.
Okay, thank you, Chair. And this paper is for information rather than approval. There is a lot in here, but I will summarise what I feel to be some of the key points as ever, and then open to the committee for any questions or comments. The report provides a review of primary care workforce matters in 22-23 with a focus on analysis of workforce data and a summary of how the GM Integrated Care Board Oldham locality training budget has been utilised in this period. There are some caveats around the data. There are some issues with reliance and accuracy and timeliness. However, when you look at this data over a period of time, it does paint an important picture for you. In the period from April 22 to March 23, our training budget has been used to fund recurring streams such as clinical cover that facilitates practices closing for half day every month. And through those training sessions, we provide a rolling programme of clinical and administrative training for general practice in Oldham. If we consider the first paper today, the LCS paper, last year we did a half-day training session focused on respiratory, which was very well attended by general practice in Oldham. Our next training session in July will focus on women's health matters. The ARS funding, which is the Additional Roles Reimbursement Scheme, I'm really pleased to say we're seeing a significant increase now in the projections in respect to staff that are going to be brought into Oldham as a result of that scheme. In section 3 of the paper, there is quite a detailed breakdown of current staffing levels in Oldham. And Mike, noting your previous comment about a review of services in West Primary Care Network, I can break this down further into PCN for you. So that would be quite a straightforward piece of work to do. What I really want to draw out here, especially in light of the discussion that we've just had, is that it should be noted that in spite of the impact of the pandemic on staff, numbers of staff in Oldham have not changed dramatically in the last 12-month period. In fact, the number of whole-time equivalent staff in general practice in Oldham has increased by 7 whole-time equivalents, and the headcount of staff has increased by 1. So while we don't compare well against the national picture. We are managing to sustain at least the numbers of staff in general practice in Oldham. During that time, 3 practices have sadly closed, and we've just been discussing Block Lane, with the majority of patients migrating to neighbouring practices. So while the number of practices has reduced, thankfully our overall numbers of staff have not. In the workforce data, I'd like to just highlight the issues surrounding practice nursing. The practice nurse numbers have decreased slightly, and this is an area of concern for us. However, we have put in place an innovative nurse training programme in Oldham. In September 2020, the CCG as was recruited 5 nurses to participate in that first wave of the pilot that saw the nurses take up 6-month placements at 5 Oldham practices. It was successful, and we do continue with that scheme. We've now got a further 6 qualified registered nurses who are new to general practice working in Oldham practices. The idea being that following this training session, they take up permanent posts within general practice in Oldham, and many of them have chosen to do that. So while practice nursing does continue to be a huge area of concern for us, what I think is really important that the committee here is that as a locality we are being very proactive in trying to sustain and increase that workforce in Oldham, and we are committing a lot of time and resource to that agenda. I realise that there's a great deal of content in this paper, and I've only pulled out some of the key highlights. However, I am happy to take any questions or comments that the committee has on any area that I've mentioned or any other area highlighted in the paper. John.
Okay, thanks, Marion. And we could have been here all day just presenting the paper.
Yeah.
It's a pretty detailed paper, and I think
is.
it's probably the first pass at this subject rather than the only pass at this subject. And I think, we may well choose, I think, from today to take some of these individual components and bring them back and do a bit more of a deep dive on some of them. That said, I'm going to start with you, John.
Thank you very much, and thank you, Marion, for this paper. So there are a few headlines, because workforce is everything, as we know, in the NHS. Not everything, engagement and all the rest of it, but workforce is key, and we ignore it at our peril. And so, I mean, the first headline is, I think, the practice nurse programme. I have sat here in a cold sweat and gone home and not slept properly, seeing figures that showed that 100% of our nurses were aged 50 and above. When nurses get to 50 and above, they are excellent. They are as good, if not better, than doctors. They deliver on long-term conditions, etc. But everybody ages, and my real concern then was that we were going to end up not having any future workforce. So the fact that your charts there, Marion, show an ample amount of nurses coming through, younger, vibrant, bright, many of them converts from other disciplines, although we actually have a pathway now, Chair, that you can join as an unqualified healthcare assistant and train all the way through to be a nurse prescriber in Oldham, and we have some people who are well into that pathway now without having to go to university. So the practice of nursing is not just planting trees for other people to benefit from, but it is a real impact now. And certainly some of the older nurses will say that what keeps them vibrant and real and reflective and in practice is the training of those younger nurses coming through. So I think that's something that we should really acknowledge. And Tarek's work and Dr. Laura Nielsen, who's the CD for this, have really come through and have been amply supported by the PCN CDs who see that this is a pan Oldham benefit. Just a few other things then. So, we have had all the turmoil and the quality improvement in Oldham and not actually lost our GP numbers. Our GP numbers are not where they should be. I would just point the committee to the second highlight, which is our whole time numbers of GPs and our full-time equivalent numbers, which is high, near to 100%, those GPs are working, is extremely high. So it's 77%. That's well above national average. So our GPs are doing a lot of work. And so sometimes I might get a bit grumpy about GPs attending things or making themselves available, but I am really cognizant that our GPs are not swanning about, but sitting at desks and sitting in the neighbourhoods, seeing people. The vast majority of our GPs are busy seeing people. And certainly that's something we need to work at. I take your points, Mike, about it would be good if we could get some additional funding, if we could get some additional resources. So I wanted to say, there's some really amazing good news in the practice nurses, but it's taken a lot of work and it's taken 4 or 5 years to get to this position. Our GPs, it's remarkable how well we've sustained the number of GPs, but just be mindful that they are above, as is in deprivation, working really hard compared to average across the country. And then the third thing is the R's story. So we've seen this R's story, haven't we, for the last couple of years. And so again, really grateful to this committee for the encouragement you've given to me and my colleagues, grateful to Marion and the team, grateful to the PCN leaders and particularly their practice their management support, because it is an emerging story of us increasing our R's workforce. And that is part of the answer to better access for our patients, better services for our patients, and sustaining that GP workload that I've also described. So still some work to do, but those are the 3 highlights for me, Mike, and I'm really grateful. And I think the training, it's so great to be post-COVID and to be in rooms with people again. That's the stuff that we need to work on this year, getting together again. Those once a month, half a day, don't really affect any access numbers, but they absolutely affect the quality of what's delivered in the rest of the 99% of the month. And I'm very grateful that teams do take that seriously and there's really good attendance at our training sessions. Thank you.
I'd agree with all of that, John. I think a real focus this year on ours, I think, has to be a priority for us. We're just at the foothills of some work around demand, and later on today, myself and others will be involved in a bit of a workshop about trying to understand patterns of demand. And one thing I'm pretty clear about, we are fighting tooth and nail to try and keep the number of GPs in Oldham that we currently have. But we also know that those GPs are seeing more patients. There are more appointments now than there were before the pandemic. So we generally have and are now in a place of probably having less than the national average of GPs per head of population, but more appointments per head of population, or the England average. So it's not hard to see why primary care is really, really busy. And it's not hard to understand that deprivation has a material impact on the number of times that people see their GP in a year. It's more basically in deprived and impoverished areas compared to affluent areas. So there are some real things I think we need to tackle once we start putting the data together, now that we have access to it and understanding the pattern a little bit more. I definitely think, Marion, that it's probably worth yourself, me and John having a conversation with the local authority and some of our PCN directors, and let's try and get to the bottom of what can we do as a whole town, because GPs want great schools, they want great houses. It's not just about less complicated patients, for example. There's a whole story here about we can attract loads and loads of GPs, but if there needs to be an attractive offer in the round, and we need to join this up across the system. So I think the paper says an awful lot of really great things. I think a real big focus on ours this year, getting to understand the data a lot better, and I think bring some of these individual components back. But let's start a piece of work with local authority now about what can we do in partnership to start driving up the opportunity for GPs to come and practice in Oldham. Okay, if there's no more questions, I'm going to move us on to the next agenda item, Marion, which has gone find my agenda for, which is any other business. Does anybody have any? Okay, some more. You nearly got away with it then. You've got to be quicker on the button there, mate.
Sorry, I didn't want to give everyone too much extra time, but I won't take up all the remaining time either. Just a quick point to raise. I thought this might be the most appropriate place. There were some conversations between ourselves and Mark Drury in terms of doing a possible exercise in reviewing PPGs across Oldham, because the understanding was, this is probably going back a year, that the CQC had picked up at least one or two practices that they had noted hadn't gone back to having functional PPGs, and therefore question mark around, well, where are we in terms of as a locality? So that is something that we would like to pick up and still be part of. And I just thought whether it would be worthwhile raising it here and seeing if that's something that people in this meeting agreed with, and seeing if there's a potential piece of work there for us to be engaged with.
Okay, thanks, Timo. Same agenda item, Marion, or something different?
No, the same item. I
Of
just
course.
wanted to say thank you to Timur. I know that practices that have received your support around PPGs in the past have found that really valuable. I really appreciate the offer, and I'm sure lots of the practices in Oldham would. So I would suggest that we get together outside the meeting, and then we very clearly communicate the support offer that you can give around PPGs. I'm really happy to encourage our practices to liaise with you and work with you over that, because I think it would have massive benefit to residents in Oldham and to them, for practices in respect to their CQC inspections, but more importantly, about how they engage and listen to the local communities that they sit within.
Brilliant. And I think the time's come now. I know that there is a bit of a challenge with PPGs across the country, in that the demographic is very much the same, and it can feel a bit dry in some respects. So I think if we're going to look at a refresh, we can absolutely do a drive to attract different age demographics, etc., and make sure that they are fit for purpose and not just kind of, a small number of friends are getting together.
Okay, so we'd like to ask you, Timur, then to lead a piece of work to bring back, feels like September will be a reasonable time, about state of the nation of PPGs in Oldham, which tells us what it looks like, gives some recommendations about what needs to be done, and sets a work programme off for the future, if that's okay. And we'll put our resources next to you to do that, Timur. Fabulous. Is there any other business? Okay, thank you very much. The date and time of the next meeting is the 3rd of August, I believe. Thank you very much.
Thank
We're
you.
finished, New Image.
Thanks.